where they actually diverge in terms of their cardiac remodeling. Some go into the more pathologic category. So that's an active area of debate and research, but something to look into down the road. Okay. But let's move on. Shown here is a 67-year-old female with liver cancer. I'm not going to say what kind, but this is a nice oldie and goodie. And do we have any general fellows on the line? No general cardiology fellows?
I'm here, Dr. Yang. I don't know if you can hear me. George Waits.
Hey, George. So what do you see? This is a nice oldie but goldie kind of case that shows up in the echo lab every now and then.
Yeah, so I can see that the right side of the heart has enlarged chamber sizes, definitely marked enlargement of the right atrium. And I would say the RV also looks larger than the LV cavity. I would add, looks like in terms of function, I think the wall motion looks fairly normal, both right and left, contracting appears normally. I don't see any.
I get the feeling George is trying to be thorough, but he's beating around the bush. There's a clear abnormality here. What do you think of the valves?
Obviously. Okay, so there's a apical displacement of the tricuspid annulus, I think. But gosh, and now the clear abnormality is this rip roaring TR here, I think.
Yes.
Yeah.
And if you look at the RV3 chamber view, what do you think of the pulmonic valve?
Okay, so in the 3-chamber view, it looks, let's see, yeah, so it looks like there is also some stenosis.
Yes.
As well. So this is starting to look, let's see. So we have pulmonic stenosis.
What's the mechanism of the tricuspid regurg?
Yes, George has commented. He said it's rip roaring. Yes.
But the mechanism of it?
Yes. Are you there, George?
Yes, I'm here. And on the question of the mechanism of the TR, I think there's some annular dilation for one thing, but with the enlarged RV, I think that'd be one. That's the etiology I would suspect.
Okay. So if you look at the mitral valve, the leaflets are moving. What's the tricuspid leaflets doing? Hello? For the sake of moving on, I'll just point out.
Carcinoid, sorry.
There you go. You actually, I was going to ask you what cancer you thought you had.
Fixed.
Yes. So,
sorry, my audio's been in and out.
Because of the HIAA, the serotonin effects from the carcinoid, the tricuspid valve and the pulmonic valves have remodeled, and they're all tethered and fixed. They're no longer moving, and so this is rip-roaring TR, as you pointed out, that's caused RV and RA remodeling. So much so that's now impinging on the left side. But this is a severe TR in the case of a carcinoid patient. Okay, very good. Thank you, George. Now, when it comes to valvular regurgitation, we actually do the method of quantifying the RV, EDV, ESV, get its stroke volume, and we actually get the PA systolic flow, and we get the TI regurgitant volume from that. So very identical way do we do it to MR. And the reason why we choose to do it this way, as opposed to try to do any kind of direct method on the tricuspid valve, remember where I said phase contrast, we had to set the plane perpendicular to the blood flow. The tricuspid valve is moving in and out it has some apical descent when the RV is contracting. So you're never sure you're in the same area, and so you're never sure if you can accommodate for the actual mitral annular level, and be sure that you're measuring the true tricuspid inflow, and that can affect the tricuspid foreflow and the reverse flow as well. So trying to quantify it using direct methods is challenging with the atrioventricular valves. So that's why we use the method of taking the ventricular stroke volumes, assuming no other issues, and then taking the PA systolic forward flow and subtracting the difference to get the TR regurgitant volume. One group did try to do quote unquote aliasing, where they tried to estimate the EROA using tricuspid valve, but for obvious reasons we haven't heard too much about that. That's not considered as reliable and may be misleading. But more importantly, our own group, Yang Zan, when he was still a fellow here, did some very important work where he actually looked at all comers, all patients who came to the CMR lab, and had TR estimates done. And so he along with Dr. Shaw and all went through and did a survival analysis and found that there are different cutoffs that indicate lower risk, intermediate risk, and high risk, depending on the presence of depending on the degree of tricuspid regurgitant volume severity and tricuspid regurgitant fraction. This was just published last year, but this was great work he did. This led to him becoming a young investigator finalist in the ACC conference the year before. But this is important work that may lead to some revisions of our regurgitation guidelines down the road. Okay, and this is just showing more of the different data. Shown above are the Kaplan-Meier survival curves, showing mild, moderate, severe using his classifications and associated survival. Mortality, and then shown here is the hazard ratio for mortality, the spline curves, showing that as regurgitant volume increased, so did the adjusted hazard ratio mortality. Same with the tricuspid regurgitant fraction as well. Okay. Moving on, we're going to shift gears and move into Huey's and Valeria's world a little bit. And just for time purposes, I'll walk everyone through this. Shown here is an RV3 chamber view. You can see the RA and RV are pretty generous, functions a little bit off. And then you can see a lot of flow through the pulmonic valve, not only in systole, but in diastole. And the RVOT view, this demonstrates the same, that there's a lot of backflow as well. And then shown here is not so clear-cut a cut of the RV, but you can see everything that looks a little bit more generous. And please believe me when I say there's RV apical dominance. The RV is enlarged. So most tetralogy patients back in the day, when they underwent VSD closure and fixing of the pulmonic stenosis, a lot of times I had a pediatric cardiac surgeon tell me, and everyone does, that they actually take their pinky and just shove it into the RVOT and rip up the pulmonic valve. And unfortunately, this 35-year-old patient with tetralogy of Fallot had the consequence. He has rip-roaring pulmonic regurgitation. Now, for this method, because the pulmonic artery is pretty fixed and doesn't move around much, we can actually do direct pulmonic regurgitation methods with a little more confidence, and just like we do with AI to estimate PR. Although I still insist on the text doing IVC and SVC inflows because sometimes the turbulence in the forward flow of the pulmonic artery makes it harder to quantify the forward flow accurately as well. Okay. So I won't belabor this. But other than to say yes, as I mentioned before, the congenital hard guidelines from ACCHA do recommend serial CMR in patients with with their RVs affected. There has been a metaregression analysis done to look at the impact of RV dilatation and issues and its effect on survival, etc. Okay, but I won't belabor this. belabor this, but there is actually a large cohort, the indicator cohort, for congenital patients that they're studying these kind of things as well. And they have shown that again, saying the same thing again over and over again, the fact that RV enlargement, increase in RV enlargement, increase in RV mass does portend a grimmer prognosis in these patients. Okay. And last but not least is a patient with sleep apnea. Shown here, you can see the RV is very generous. RA is also very generous compared to the left-sided structures. You can see the RV is not as hot. And then I'm showing the pulmonary artery here, and this is a quick, dirty way of gauging the PA size. In this case, the PA is enlarged relative to the aorta. If the aorta is enlarged, all bets are off. You should go and actually measure it. In this case, we often see that see in radiology reports on CT that the PA is enlarged, suspect pulmonary hypertension, and in this case, they are correct. But yes, the PA does tend to dilate up, so much so that some people have come up with entire classification systems just based on PA diameter. The most specific cutoff in the CT world is using a cutoff of about 3.4 centimeters, but normal is anything less than 3. Anything above 3, between 3 and 4, there are different tiers. But keep in mind, 34 millimeters and above is considered probably a little more specific for pulmonary hypertension. But keep in mind, just because you see enlarged PA, that does not automatically mean pulmonary hypertension. Pulmonary hypertension is actually a pressure diagnosis, a mean pulmonary pressure diagnosis of greater than 25 millimeters of mercury. But that's the formal criteria by the World Symposium on Pulmonary Hypertension that meets every few years. But PA size can dilate up for any other reason. You can have PA aneurysms, just like you have aortic aneurysms from connective tissue diseases, etc. You can have high flow slates like patients with anemia, especially our cirrhotic patients. The PA will be enlarged along with everything else in the body due to the high flow states. You can have mycotic infections from tuberculosis, et cetera, that can lead to that. So just because the PA is enlarged, don't automatically jump to pulmonary hypertension. And my tendency is I tend to call enlarged PA and just leave it at that. Let the clinician ordering draw their own conclusions from that. Okay. But can we do it in CMR? There was some work back in the day where they try to look at the angle between the LV and LV walls in the septum. So they try to use septal angle, and I'll show that there's actually been some advances since then, but obviously this hasn't taken off because most centers don't use this for pulmonary pressure estimations. Okay. I'm not going to go into that. RV insertion LGE does come up every now and then. I have been asked whether or not it has any kind of prognostic impact. Turns out it does. So in pulmonary hypertension and HOCM patients, RV insertion LGE does have an effect. Does have an effect on clinical outcomes. So that's why we still note it in our reports when we do it. Okay. Well, what about the future? Parametric imaging, so being able to do T1 magnetic characterizations, T2 characterizations, T2 star characterizations are all the rage, not only for the LV, but people are trying it with the RV. And there are 3D parametric mapping techniques out there. So hopefully in the near future, we'll be ironing that out, hopefully having some research experience with that, and then introducing it into the clinical clinical reporting as well, clinical use. But it's all the rage. It's one of the things that come up now, so much so there are now parametric mapping working groups in existence in the CMR world. Okay. I mentioned that the RV is not the most clear-cut geometric structure. 3D Cines techniques are on the horizon as well. Many physicists and computer scientists are working on how to do accelerated techniques, even free breathing, where you don't have to hold your breath. A lot of the breath hold maneuvers we do are breath hold require breath holds to avoid diaphragmatic motions. But with compressed sensing, post-processing methods, hopefully we'll get there, and we can just do a push button, acquire the RV, and then get you measurements of the RV based on that. Not only RV, but the LV and everything else as well. One exciting thing that, sorry for the potato quality image, but a couple of years ago, I was excited when one CMR researcher, a clinician, presented virtual CMR oximetry, where they were actually able to do a T2 prepped imaging techniques to quantify differences in the O2 sat levels of the RV, LV, and different blood compartments. So people are working on that, and hopefully we can do that and provide an initial non-invasive oximetry run. So that's on the horizon and very important in congenital patients with their RV, PA, and RA issues. And of course, no talk is complete without discussing 4D flow. This isn't working, which is fine, but I mentioned phase contrast techniques. Most of the time we use conventional 2D phase contrast, but we actually do have the ability to do 4D flow, so you get three phase contrast in all three dimensions and create wonderful streamlines, path lines, and describe not only velocities, dominant velocities through the different chambers of the heart, but also discuss 3D flow characteristics like vortices, turbulence, etc. But that's on the horizon as well. So much so that one thing that came out of the SCMR presentation conference that just happened a couple weeks ago, there's actually one scientist working on using 4D flow vortice formation in the pulmonary artery to try to do pulmonary artery pressure, mean PA pressure estimations. So this is a very active area that's underway. So with that, I'd like to summarize, and since we're a few minutes past the hour, but just to re-summarize, hopefully I gave you a good talk about how CMR can give different pieces of information about the RV, about its size, its function. Hopefully I convinced you with the data I shared that it has very great reproducibility and repeatability, and hence it's used for establishing accurate volumes and accurate EFs. It can see LGE in the RV, and if there's RV infarction present or insertion site scar, those are important prognostically, and so we do try to include those findings when we see them in our lab. And there's quite a few new techniques where CMR can not only quantify valves, valve function, valve pathology, etc., but looking at pulmonary pressures, looking at RV myocardial characteristics. But those are on the horizon and hopefully coming soon in the next coming years as well. With that, I want to thank everyone for their attention. And are there any questions? Any questions or any comments? Any of the other attendings have any other thoughts? Everyone is...
Eric, there are some questions, Mohammed here. There are some questions I see on the poll everywhere. If you can see the studio.
Give me a second. Can we assess RV myocardial viability in CMR? If so, are there any particularities comparing it to LV viability assessment? So for that question, that's an excellent question. I don't think there's anything outside of research, but we all have hypothesized that because you can actually image the LV and RV a bit better in systole, because everything's thickened, that you may be, and actually that's what we kind of do in perfusion imaging, that one could in theory do some kind of a viability assessment using perfusion techniques. But it hasn't been accepted widely in clinical use. So nothing that's been widely adopted, I should say. mainly limited to research purposes at this stage. Second question is, can CMR be more effective than echo in the assessment of lead-induced TR? Yes, with a caveat, because the issue with the patients with RV leads is they tend to have a big generator. They have the can, and so that can create sometimes substantial metallic void artifacts that limit our assessment to see the RV completely. So, provided that's not the issue, we, as I presented before, and those metallic void artifacts can also affect the PA flow assessment. Provided that's not the can isn't an issue, the generators don't cause effects. The RV leads themselves don't create a big issue in terms of quantifying the RV stroke volume and quantifying the PA flows. So yes, we can actually assess TR and actually see the structures to some degree around the tricuspid valve. But yes, it can, provided there's no metallic void artifacts from the can, provide a very accurate estimation of TR severity in lead cases. I think those are the only two questions. Anything else? When RV function is depressed, especially due to an akinetic or dyskinetic interventricular septum, how to tell apart from the LV from RV dysfunction? That's a good question. That can get challenging because we've had case conferences where we got lost trying to figure out where the wall motion was in the RV. Because as I mentioned before, the RV motion is not the most straightforward. It's not like this LV where everything comes in cleanly. It actually has a kind of peristaltic motion. There's differential activation of the myocardium from inflow to inflow apex to the infundibulum. So that can get challenging, and the nice thing about CMR is since we don't have a limited field of view, we are able to get good windows, so to speak, and see everything. In a dedicated CMR study where we're actually looking for RV motion, where we do full long axis stacks in addition to the short axis stacks, we and do the full RV3 chamber, and all people get RV3 chambers at our institutions. But if we do RV2 chambers, then we can reasonably comment on the wall motion in the RV. And get more definitely more reliable assessment of wall motion in these patients. Yes. When there's a bundle branch, then that becomes a little more difficult. But we're still able to visualize everything and play it over time and figure it out over the cardiac cycle. Okay. Any other questions or any other thoughts? Okay, it's 10 past the hour. But thank you everyone for attending, and thank you for your attention. Hopefully we'll see you all again next week with the next multimodality.